just to set expectations here, it's still governance financing, and we're trying to reflect on resilience. So it's not a research study on resilience, but as it's written on the slide, so I'll try to reflect a bit based on the work that we've been doing at QMU over the last few years on the health system resilience in Northern Syria. And why we are interested in Northern Syria, because as you all know, it's an extremely fragile setting. And now we are maybe towards the end of year 13 of the conflict. Yeah, 20. Yeah, so towards the end of the year 13, and then as you can see from this YouTube video from The Guardian, that the infrastructure in Northern Syria is severely damaged. And in addition to that, and with the protracted nature of the crisis, we have been dealing also with increasingly constrained funding for humanitarian assistance. So in addition to what I'm trying to describe as a chronic stressor, again referring back to Sophie et al., the new paper on the conceptual reflections on resilience, but we have also, in addition to that, many waves of displacement. Now, the Northern Syrian context is dealing with at least 3 million internally displaced people, and also we have other multiple shocks, such as the recent earthquake, and this is the video showing the scale of that earthquake back in this year, actually, back in February 2023. And then also the cholera outbreak as an example of additional stressors and shocks, sorry. And the cholera outbreak by itself gives us an example of how it's just, the interconnectedness between the very bad infrastructure, like the WASH sector in terms of water and sanitation, and its impact on health. So what we're trying to do is actually, and I'll be trying to reflect on resilience based on, or before that, sorry, just still in the highlights on the specific context. And as well, in Syria, we have really a complex political and military dynamics in the northern part of the country. So if you already know, so for instance, this is the area where we have the control of the Syrian regime, so the Assad regime, and then in the northern part you have also a lot of different actors. So to the west, where we focused our research, you have a mix of armed groups supported by Turkey, but also de facto authorities which are considered as unrecognized internationally, except from Turkey sometimes. And then also you have a lot of other groups. And in the east, you have the Kurdish groups, where they are somehow recognized internationally by the US and allies, but they are not considered legitimate by Turkey. So it's again reflecting on the challenges and the dynamics there. And similarly to the white areas from Egbert's presentation this morning, you have a lot of black areas in Syria, like especially when we talk about those areas where it's still under terrorist groups and so on and so forth. But you can tell, as I said, from that it's challenging, and the lovely lines now, they are not always the same, so they can keep on changing, especially unfortunately in the west, where this red line was down below, and then it kept on moving when the Syrian regime gained control again over some of the areas. So I'll try to reflect on the health system resilience based on, as we said, 4 studies. We conducted them. They were affiliated with ReBUILD for resilience, but they were conducted in collaboration with WHO, the field office of Gaziantep, and also WHO Europe, MIHAD, which is a French-Syrian NGO. It's called, before that, it was called Awesome France, and the European Commission over 2 years. So the first study looked at an integrated service delivery network in northwest Syria and used a mixed method approach based on GMB workshops, desk review, semi-structured interviews, and a survey with beneficiaries. The second one looked at MHPSS specifically, so the delivery of mental health and psychosocial support. And then for the last 2, we looked at specifically private sector engagement, or in other words, the role of private sector, because there is a growing activity there, as I'll reflect on in a bit. And we looked in the last one a bit on the healthcare utilization across sectors, whether people are getting services from the private or the NGO sector, or in some places in the east where we still have a presence of the public sector, and then the reasons why they are getting, and looking at some inequities in accessibility to care across these specific set of actors. So after, as I showed in the video, so you can tell that the first years of the war were actually, how can I call it, characterized by a consistent attack on the health system. And Fuad and colleagues worked a lot and wrote a lot on the weaponization of healthcare, and how we had at least 600 attacks and 1,000 or at least hundreds of providers and health providers killed in that few years, which meant for us that the public sector, especially in the West, was collapsed completely. So to fill that gap, we had the emergence of the NGO sector. And the NGO sector, specifically from the first study, and I'm talking about the time frame between 2017 and 2021, when we looked at that specific arrangement, they created a coordination mechanism to start mobilizing resources and focused on essential health packages, specifically across facilities. And that network started in an area near the city of Idlib in Sarakib, and then because of the movement of people and the military attack, it moved up to the borders with Syria, which is now called the Harem network. And that was, again, the aim of the first study, to look at who and how this was implemented and the kind of a bit on the outputs and outcomes of that model. It was supported by a range of donors over the years, and it was, Karen and Sophie might remember, it was coordinated or led by WHO. It was like, sometimes they wanted to say it's coordinated by us, but not led by us, just to kind of, it's a responsibility kind of issue. But it's coordinated by WHO and led by a local implementer. And it put together a set of at least 30 facilities after a pilot with 10 facilities to deliver services. And just to start adding a bit of a resilience word or a resilience term, so they were able to kind of work on standardizing inputs, processes, and reporting. And we thought back then that it might be a seed model of care for post-conflict recovery. But I added just this question mark because in the third study, when we looked at private sector engagement, you can see that this model is at risk. And I'll get back to that later, in a sense that now with people being in dual practice and with the emergence of economic activity, so now providers might be interested to shift away from the NGO sector. So how to protect that and whether we can keep the system resilient or not, this is one of the questions that we're trying to reflect on. So still on the network as a model of care, it helped and it increased health coverage. So their target was about increasing 30%. But again, as we reflected on the paper, which was published a few months ago. So 2 of the studies were published and the others are in the pipeline. So reflected on really whether you have a kind of what we called it the spillover effect. So we're analyzing and we're trying to compare network facilities with other non-network facilities, but it's not really easy sometimes to draw the line between what was the contribution of the network to health service delivery versus the contribution of other facilities. And then we had some evidence that this network focused on a range of services, including NCDs. And again, it's the same comment that Fuad made a few days ago, in a sense, or yesterday, actually. It was a long day. So yesterday, in terms of NCDs being about hypertension and diabetes in those specific settings, but also we had some evidence from the surveys on improving access to care and health outputs, mainly for reproductive health. So for NCDs is less visible, and also, but still the network facilities did better than the non-network facilities in a sense. For instance, detection or screening for eye complication was better there, but for both it was still as an indicator low. So the same kind of an approach was replicated for mental health and psychosocial support. So we had in the year 2018 or around that year, a specific technical work group for MHPSS. And that really led to start thinking and push donors first, but mainly actors, to do an assessment of the MHPSS needs among health workers and communities and try to improve the MHPSS response. So the key elements of that specific response in terms of MHPSS was about training non-specialized health workers, so the task shifting, and try to at least have a group of non-specialized who can support in delivering MHPSS services, because I think, if I remember well from the data, that the whole western part had actually 1 psychiatrist or 2. So by just to tell how much deep is the shortage of health providers. and trying to improve funding, although funding remained as a problem because specifically for MHPSS, it was not just intermittent, but very kind of a short-term funding each now and then for 2-3 months without any long-term funding for MHPSS. But they were able to fill the gaps in terms of the availability of medicines. But again, going back to the reflection on human resources, the issue was who might be able to prescribe those medicines rather than the availability of medicines and so on. And that's, again, one of the GMB workshop outputs from that second study. And we were able to see also some, based on the discussion and the model that we created, that this approach led to reducing stigma, for instance, especially it was integrated with other facilities, so people might be able to get to the facility to get the support needed. And also it helped with them having better outcomes as they describe them and being productive again in the community. But just to say, there is an inequity here between health workers and other community members because health workers reported better outcomes in comparison to other community members. So in addition to that short-term funding, as I mentioned, we still have the issue of skilled health professionals, especially for NCDs and MHPSS. Adding to that, from the challenges side now, we have an issue of the fragmented stewardship in the region and the limited organization capability of local health authorities, and the limited oversight over the public, over the health sector in general. And that was confirmed or emerged again when we discussed or analyzed the private health sector in Northern Syria, because even for registration and licensing of these facilities, who should be the kind of the legitimate body to do that? So is it HTS, in a sense, those de facto authorities where you can register private practices, but it's not recognized by anyone else? Or is it the Idlib Directorate, which is kind of still considered as a neutral entity? And just, I think we had a discussion in one of the breaks, and going back to, I think, Egbert's point on the neutrality of the health sector. It's the same in Syria, but it was kind of a deliberate act by de facto authorities to keep the health sector as neutral because they cannot afford working in that sector. So NGOs can still operate. So but I think in the last few months, we heard that probably they now decided to again intervene and take over the health sector, like what we did for the education sector, for instance. So I think, again, all these challenges put, as we said, achievement at risk. So the transition of the network and other programs to a sustainable model is at risk because, again, of these fragmented or these elements of fragmented governance and the kind of sometimes also the exclusive government because the private sector wasn't there and they are still, now they are kind of a growing sector. But it is unregulated. The private sector there is selective. So they're selecting really the highly profitable services, C-section, of course, and other examples, but not really working in delivering any care where there is a need for them. As I said at the beginning, we are concerned about competing for those limited human resources because they already in dual practice, and people who know the history of the health system in Syria, it's similar to what's the scenario in Lebanon. So health providers were already in dual practice before that. So it's just about the private sector disappearing and now re-emerging again when you have kind of a bit of stability and economic activity. But this, as we said, and as we analyzed in the last survey, it's inequitable because people, depending on their socioeconomic status, the ability to pay, are those who can access private services in comparison to other people. On the last slide of findings, so we had, just to say it here, it's written here again, we have a high but inequitable utilization of private services, especially in the East. So because economically the East is now considered as doing better than the West, and for some services such as antenatal care, gynecological services, suggesting, as I said, a potential pro-rich distortion of the system similar to other countries in the region, and then by that I meant Lebanon. But if we need to look at the framework, again, of resilience, from across all studies, we know that, for instance, other elements, like these soft elements of emergency preparedness or strategic planning and or the use of data, especially, again, on private sector, are still obstacle in terms of resilience capabilities. So just to conclude, again, we're talking about a fragmented and highly fragmented context in Syria, a lot of issues with infrastructure, but again, we had some opportunities and the system showed some adaptive and maybe absorptive capability in terms of putting some seed models for the future, but issues around the human resources and other issues are really putting this improvement or this resilience capability at risk for the future. And here are all the partners for the different studies for this part. So that's me. Thank you so much.
Thank you so much.